that, I'm going to pass it over to Dr. Kearns. Dr. Kearns is joining us from Illinois, urologist practicing at North Shore Urology. But after finishing his training back over at the Columbia, and I'll always say it, I'm Midwest girl, so I don't pronounce anything that has any flair very well. But Columbia University, Valegos,
Fabulous. Yeah.
yeah, physicians and surgeons back in 2010, but really knowledgeable with prostate cancer in this space. So we're really, really excited to have him join us and share his expertise. So with that, Dr. Kearns, I'm going to kick it on over to you. I might, if you see me pop up, that means that there's a question in the chat. Otherwise, it is your show this evening.
Perfect. Thank you so much, Erica. Thank you everyone for being here tonight and joining in to talk about these tests. So Jamie Kearns, I'm a urologist up here in the North Shore, now named Endeavor Health. And basically, prostate cancer is my whole practice. And in doing so, I've come to really use and appreciate these tests that we're going to talk about tonight. And I'm going to go through a lot of cases that I find very relevant. So just an outline for tonight, we're going to talk a little bit about what these tests are, a little bit of the science. But most of what I'm going to do is talk about some of my cases and how I really do find this useful in my day-to-day practice. Please do put questions in the chat as they come up. I'm happy to try to answer them as we go along. And at some point, if we want to do a break for questions, I'm happy to do that as well. So without further ado, as we're looking at the prostate cancer diagnostic pathway, it goes from screening to patient selection. How do you pick who you're going to biopsy? You're going to get your results from the biopsy, and you're going to be either cancer negative, localized prostate cancer, or in some patients, you're going to see more advanced prostate cancer. The tests that I'm going to spend the time talking about tonight fall into the how do we make sense of the biopsies that we've gotten. I'm going to go into the confirmants. This one really is the only biomarker that helps to determine what to do with those negative biopsies. And so keep in mind when you're doing prostate biopsies, it's less than 1% of the prostate you're sampling. If you look at the old studies, 30% of patients, 30% false negative rate, if you were to rebiopsy a lot of these patients, you're going to find cancer in a significant number. I do think it's a little less than 30% now in the world of multiparametric MRI prior to biopsy, but the point is still well taken that you're not catching all the prostate cancer and all the significant prostate cancer on that initial biopsy. You also want to avoid doing repeat biopsies unnecessarily, and the negative predictive value is 96%. And you want to reduce costs to the system as well, especially as they begin to align incentives, and this actually ends up saving money, so it's useful across the board there. So what does this do? So this is the detection of clinically significant prostate cancer. And so three tumor suppressor genes that are important for prostate cancer regulation. You're going to see either DNA methylation positive, which you'll add to clinical risk factors, or DNA methylation negative. I like the next slide better, though. So DNA methylation is basically any gene that's methylated is going to be downregulated. So the tumor suppressor genes that we're evaluating with the confirmed test if they're methylated, you're going to decrease expression of tumor suppressor genes. So when I'm counseling or when I'm talking to my residents and teaching them how to use these tests, I tell them DNA methylation is essentially cutting the brakes. And I think that that's the best way to think about this. So with increased methylation, you have decreased tumor suppression and more likelihood of there eventually being cancer. That's the other important thing with this is that confirm, I personally believe requires time before you do that next biopsy to figure it out because these tumor suppressor genes are downregulated now, which I think means that in some future state, I think about a year in my own practice, may be more likely to see a cancer that wasn't even necessarily there. So not even that I missed it on the biopsy, but it wasn't as mature as it'll be in a year when I do that repeat biopsy. So the mechanism of action makes sense. You've got detoxifying cell cycle regulation and apoptosis. Um, just so you know that they make sense. I'm not going to go too much into these. GSDP1 is commonly found in prostate cancer, APCs for cell division, and RASF1 is cell cycle progression. I love this slide. So this gets into the epigenetics and tumor regulation that you're going to see around the tumors and around the cancer. So basically, if you do a biopsy, sure, you can hit the cancer, and that's great. You have your diagnosis, but the area around the tumor can also have these epigenetic DNA methylation changes. And so let's say rather than hitting the tumor, you hit this next to it, or you hit this next to it. Well, if you hit the methylation, that gives you a signal that there's a tumor in the vicinity, or maybe a tumor that's going to develop. Um, if you hit the normal, it's not going to be methylated, and that's just going to be what it is. But if you're a little further away, you might actually hit the next field. Keeping in mind that prostate cancer is often multifocal, it's a field effect disease, and so you may find it with a different primary tumor, and this just again gives you that signal. But this is how I like to think about it. I love this slide. I actually think about when I'm explaining and thinking through the confirmed test myself. So, lots of studies showing that it works. It's valid, it makes economic sense, and it is useful clinically. So, kind of a busy paper slide, and the only real takeaways are to see the data showing where the validation came from, but also that DNA methylation and confirm do increase predictive value. This is my favorite thing far and away, in how I think about DNA methylation and confirm, and how I, even with again teaching residents, I talk to them about where this fits into my practice. When we get these biopsy results back, and it's negative, you always have to ask yourself, well, what am I going to do with this? Do I believe it? Am I going to do another test? Am I going to do another biopsy? What am I going to do? And the factors I think most of us take into account are PSA change over time. Sure, rectal exam, but how often do we really feel changes in rectal exam over time? Atypia, I think a lot of us traditionally, I know I at least have used atypia as a reason to do another biopsy a year down the road, and I found cancer because of atypia. Um, Confirm blows this out of the water. So the odds ratio with confirm is essentially 7x atypia. So you can think of it as super atypia, but I think it really says, look, this is an actionable, meaningful result. And if you're seeing this, you want to very strongly consider rebiopsying that patient at some point. Um, it is valid in African American men. I know that's a question that comes up all the time. A lot of these tests are validated in very homogeneous populations, and so seeing some um, more diversity and actually seeing these studies in African American men, I think is helpful. Especially given the traditional concern that African American men are underdiagnosed, undertreated, and have more aggressive disease. But basically, it's a 95, 96% negative predictive value for the presence of prostate cancer on repeat biopsy. So if you get negative methylation, I think you can feel really good that your biopsy was accurate. Um, and if it's positive, I think you you're going to want to look at it and want to see um, if you want to do that other biopsy. Different from the GPS score, I actually really like the breakdown between the Gleason 6 and the Gleason 7 or higher cancer, because if it looks like I just missed Gleason 6 cancer, I might be willing to get away with it. Whereas if it looks like I missed Gleason 7 or higher, I really do want to biopsy this patient. So, how does it fit into the clinical pathway? You get the confirm MDX. Is it false negative? I don't know. But if the test is negative, you're just going to follow them up at some point. If they're increased risk, you're going to follow them up again, and probably do another biopsy. I don't agree with the timeline necessarily. I'm probably more in a 6 to 12 month timeline. I don't repeat biopsy my Gleason 6 patients until at least 6 months and sometimes 12 months. So if we're looking at something precancerous, I'm going to be a little bit more conservative even than that. A couple of patients of mine, though, there's one guy, 55, PSA pretty high for his age, PHI more reassuring, a little bit enlarged prostate, density's 0.15, PIRADS 4, 50/50, it's going to be something that is clinically significant, came back with negative methylation, and so feel good about continuing to keep an eye on him with just annual serum biomarkers, PHI in my hands. Uh, Another one is going to be a 47-year-old guy, so even younger, pretty elevated for a 47-year-old. PHI is actually a little scarier in this patient than the last one. 38-gram prostate, PSA density in that 0.15 range. Normal MRI though, and the high PSA normal MRI, not very large prostate is always a interesting clinical conundrum to me, but seeing negative methylation is nice to make me feel good that we didn't miss anything. As an aside, I will also say I look at all of my methylation results with my negative biopsies because I use it completely informally as a check on my prostate biopsy quality. I think that I want to see negative methylation rates a lot of the time. And if I'm seeing a lot of positive methylation, I'm asking myself, am I doing a good job of adequately sampling the prostate? Am I missing something in my appearance with the ultrasound? Am I missing something with my registration with the MRI? So it's an um, maybe too out in the weeds, but it's something that I consider.